Swayam Prabha. Digital India. Educated India.
Welcome to a series of lectures on benign diseases of the breast. This is Anurag Shrivastava from Department of Surgery, All India Institute of Medical Sciences, New Delhi. We shall take you through an initial concept of aberration in normal development and evolution. It is known by the acronym ANDI or ANDI. This concept was initiated by a group of experts in benign diseases of the breast from Cardiff Mastalgia Unit in United Kingdom. We will explain this ANDI concept by showing you a video animation film. ANDI concept of benign breast disease has been explained in this video animation. ANDI is an acronym for aberration in normal development and involution. This concept was first initiated by experts in benign breast disease at Cardiff Breast Unit, led by Professor Ellie Hughes, Robert Mansell, and David Webster. This concept allows us to understand most of the symptoms and presentation of patients suffering from benign breast disease. It is thought that nodularity of the breast, nipple discharge, mastalgia, small lumps in the breast like fibroadenoma, duct papilloma, and breast cysts can all be explained with this pathophysiological concept of ANDI. We shall explain this concept through some anatomical facts. There are 7 to 8 lobes in each breast. These are arranged like bunch of grapes, each grape representing the milk gland or acinus, and the stalk represents the major milk duct opening at the nipple. Each lobe contains 10 to 40 lobules, which in turn are composed of 10 to 100 acini. These acini are the basic secretory unit of the breast. The terminal ducts, together with the lobules, constitute terminal ductal lobular unit, known by the acronym TDLU. TDLU is the most hormone responsive and most active part of the mammary gland. The epithelial lining of the ducts and acini has a luminal and a basal cell layer. The growth of these cells is controlled by the hormones estrogen and progesterone. Estrogen causes development of the ducts and stroma with fat deposition. Progesterone causes maturation and branching of the ductolobular system primed by the estrogen. It also causes secretion within the acinus. Progesterone is also responsible for retention of water within the breast stroma. The blood levels of estrogen and progesterone change with the menstrual cycle. From day 0 of the menstrual cycle, there is a rise in level of estrogen with formation of Graafian follicle in the follicular phase. Lobules are quiescent in this phase. In the post-ovulatory phase, there is a second peak of estrogen along with rising levels of progesterone from corpus luteum. These hormones result in proliferation of cells of the ductolobular epithelium along with increased number of acini. Moreover, there is increase in the fat and water content within the breast stroma. The net result of these changes is an increase in the breast volume, compelling some ladies to even change their garment to a larger size. The increase in breast volume causes pressure on the pain nerve endings, resulting in breast pain or discomfort. This is called mastalgia. In some degree,
This mastalgia is a normal physiological response. However, when it becomes severe and lasts for more than a week, disturbing the activities of daily life, we need to consider it as pathological and treat it. Initially, in most women, there is a uniform growth of cells throughout the breast. Later on, some cells become hyper-responsive to the hormones, resulting in more growth of the ducts and alveoli in some area, resulting in nodularity. If you examine a lady with nodularity in the premenstrual phase, you will encounter pea-sized, often tender nodules scattered throughout the breast with soft and supple breast tissue in between. Marked growth of ductolobular cells along with the stroma in a localized manner may result in formation of a discrete lump in the breast called fibroadenoma. Fibroadenoma is not a true neoplasm and is now considered as part of ANDI manifestation. This view is supported by the fact that some girls experience increased growth of fibroadenoma in the premenstrual phase and reduction in the size after the onset of menstrual flow. Proliferation of the ductal epithelium leads to ductal hyperplasia, which may result in increased secretion presenting as physiological nipple discharge in some ladies. Localized growth of cells within a dilated duct leads to a papilloma formation. It has a central fibrovascular core and papillae lined by myoepithelial and luminal cells. Sometimes the papilloma may undergo infarction by torsion of the stalk, resulting in bloody nipple discharge. In the perimenopausal period, involuntary changes with overgrowth of the fibroconnective tissue around the ducts leads to ductal blockade. Dilatation and unfolding of the lobules along with pent-up secretion result in cyst formation. Initially, microscopic cysts are formed. Many such microscopic cysts may join to form a macrocyst. Thus, we can appreciate that ANDI concept enables us to understand the mechanism of most of the benign breast symptoms, mainly the breast pain, nodularity, the change in breast size, nipple discharge, formation of fibroadenoma, breast cysts, and duct papilloma. Thank you.
Now, I take you to the commonest symptom with which a lady presents to a breast clinic. This is known as mastalgia or breast pain. We should appreciate that this is the commonest manifestation of ANDI and the commonest reason for a lady to present to a breast clinic. In some form, it is almost universally present among all women. However, when it becomes severe, it is considered pathological. That is to say, when it is present for more than 7 days in a menstrual cycle, or when the pain severity is such that it scores more than 3 on a visual linear analog of pain score of 0 to 10, or any pain regardless of severity that interferes with the activities of daily life of a lady. We shall call it a pathological and treat it. Unfortunately, the concept and the treatment of mastalgia are poorly understood among many physicians, and therefore, it is rather badly treated. And let me tell you that some drugs like vitamin E, commonly prescribed by the name Evion, and evening primrose oil are wrong drugs to be used for mastalgia, as we will see the current evidence-based management in the subsequent slides. Let us recap the hormonal basis of mastalgia and ANDI. Throughout the reproductive years of a lady, right from menarche to menopause, the mammary gland tissue are undergoing cyclical changes under the influence of estrogen and progesterone. Both these hormones act as growth factors for the breast ductolobular epithelial tissue. That is to say, they cause cellular proliferation of the epithelium of the mammary ducts as well as the lobules. Moreover, there is retention of water and fluid in the mammary parenchyma under the influence of progesterone. Similarly, estrogen is responsible for deposition of fat in the breast parenchyma. The net result of all these changes is an increase in the volume of the breast in the luteal phase after ovulation. Moreover, there is varied target organ response, that is to say, under the same level of estrogen and progesterone, different cells of the ductolobular tissue respond differentially to these hormones. When a lady presents to you in the breast clinic with symptom of breast pain, your first duty is to distinguish the true breast pain arising from the breast tissue from those causes where pain is a result of musculoskeletal disorder from the lateral chest wall or from the medial part of the chest from the costochondritis, commonly called Tietz syndrome. This video clip will explain how we elicit true breast tenderness. So, in sitting position, we gently palpate the mammary gland as shown on this video. If lady complains of pain, we know that it is arising from the substance of the breast. So, this lady complained of severe breast pain on both sides. On gentle pressure on the mammary gland in sitting position, she developed severe pain as revealed by her facial expression. When we pressed the lateral chest wall over the ribs, she also had some tenderness. Similarly, pressure on the costochondral junction reveals some tenderness, which indicates costochondritis or Tietz syndrome. Basically, there are two types of mastalgia, one that is associated with every menstrual cycle, which comes around mid-cycle starting from the day of ovulation, becomes more and more severe till it reaches a peak level of pain on the first day of menstrual flow on day 27 or 28 of the menstrual cycle. With the onset of menstrual flow, the pain eases off and lady remains pain free for the next fortnight, only to experience similar pain from next mid cycle, and this goes on in a cyclical manner, hence the name cyclical mastalgia. And because the severity of the pain increases in the premenstrual cycle, we also call it cyclical pronounced mastalgia with premenstrual exacerbation. It may or may not be associated with tender nodularity, usually in both the breasts. Pain tends to be bilateral and diffuse in majority of women, and some ladies may just complain of heaviness or feeling of increased size of the mammary gland, compelling some ladies to wear even a larger size of the undergarment in the premenstrual period due to increase in the breast volume. The age of onset of this cyclical type of mastalgia is usually in young ladies till middle age to about 30 to 35 years of age. There is a strong hormonal basis to the occurrence of cyclical mastalgia, and there are many reasons to support this hypothesis. Firstly, it is strongly associated with the menstrual cycle. It is often relieved by pregnancy and lactation, and it is also relieved by drugs which interfere with the estrogen levels, such as anti-estrogen drugs, Tamoxifen, Tormifen, and Centchroman. Although the blood levels of estrogen and progesterone are not elevated in majority of these patients, there is perhaps increased estrogenic response of the breast tissue to the circulating level of the hormone. Prolactin hormone has also been studied in detail to unravel the pathogenesis of mastalgia. Studies have shown that the basal level of the prolactin hormone are within normal limit. However, when we study the stimulated response of prolactin, there is an increased activity. There is increase in TRH induced prolactin secretion in patients with cyclical mastalgia, demonstrated by Sandeep Kumar, Robert Mansell and Ellie Hughes in Cardiff. In majority of women having mastalgia, there is no increase in the risk of developing cancer in the future. Continuing with cyclical pronounced mastalgia, pain occurs during every menstrual cycle with premenstrual exacerbation. Majority of the ladies belong to the pre-menopausal age group, usually below 30 to 35. There may be tender nodularity when you palpate the mammary gland in these ladies, most conspicuous or prominent being the nodularity in the upper outer quadrant of the breast. In some ladies, this pain may even radiate to inner side of the upper arm, and then you have to distinguish from the pain of angina pectoris, especially if it is happening on the left side. Now, we come to the next type of mastalgia, that is non-cyclical mastalgia. For some reason in our community, this is the commonest type of breast pain we encounter. Here, there is no obvious relationship of the occurrence of breast pain or its severity with the particular day of the menstrual cycle, and this can be revealed by a detailed look at the pain chart. It can be unilateral or bilateral, sometimes confined only to the region deep to the areola or subareolar region or in the upper outer quadrant of the breast. Some women in this non-cyclical form may present with only a trigger point or trigger spot pain, that is, pain occurs only at a particular point and not diffusely in the whole of the breast. Teat syndrome, which is idiopathic costochondritis, usually involving second or third costochondral junction, may be a type of non-cyclical breast pain. Sometimes trauma to the breast or following biopsy of a breast lump, there may be some fat necrosis and pain may last for some significant period of time, and this again presents as a non-cyclical breast pain. Cancer is a rare cause of non-cyclical mastalgia, but this is something that we should always keep in mind. We should be cognizant that some cases of persistent non-cyclical breast pain may actually occur due to cancer of the breast. Pain emanating from the chest wall, that is musculoskeletal system, may be referred to the breast by the lady, and therefore, a doctor seeing a patient presenting with mastalgia should be aware of this musculoskeletal origin of pain, and this can be distinguished very easily by examining the lady in sitting position and trying to elicit the true breast tenderness. Continuing with non-cyclical type of pain, it can occur even after the menopause. It can occur in young ladies on any day of the menstrual cycle, and this is nicely depicted when one looks at the breast pain chart. Location can vary from different parts of the breast. It is often well localized, and some causes of mastalgia of non-cyclical nature may actually be due to diseases of the major mammary ducts like ductectasia or periductal mastitis. These patients with major duct disease present with central type of non-cyclical mastalgia. That is to say, pain is confined to the region of the nipple and areola. And trigger spot pain or trigger point pain can present in any part of the breast. The exact reason for trigger spot pain is not well understood. It is thought that pain nerve ending may be entrapped in some inflammatory or fibrous tissue such as a scar or previous trauma or surgery, or even inflammatory conditions like sclerosing adenosis may lead to this trigger spot pain. Other causes of pain in the breast are listed on this slide, such as teeth syndrome, lateral chest wall pain due to musculoskeletal conditions, pain in the region of the serratus anterior muscle, trauma in the mammary gland or in the rib cage can lead to pain referred to the breast, rarely cancer of the breast or sclerosing adenosis may result in breast pain. While evaluating the nature and etiology of pain in a lady presenting with mastalgia, we should rule out other causes of pain arising from organs like esophagus in the form of reflux esophagitis, gastritis, angina pectoris, biliary colic, pain of pancreatitis, and referred pain from the cervical spondylosis to the pectoral region. Traditionally, pain experience is recorded on Cardiff breast pain chart. Since large number of studies on breast pain have been carried out in Cardiff Mastalgia unit, this pain chart is presented on this slide. Here the lady records her daily pain experience, filling one full black box if pain is severe, half black box if pain is mild to moderate, and just a dot on the day when she has no pain. The day of menstrual flow is depicted here as letter P. We have improved upon this traditional Cardiff Mastalgia pain chart developed at our clinic in All India Institute of Medical Sciences. In this revised pain chart, we have given a visual linear analog for recording the severity of the pain on a scale of 0 to 10. The 0 indicated by a smiling face on the left side on the day when she has no pain, and 10 represented by a facial look with severe pain on the right side. And then she says her pain on a day-to-day basis. Every night just before going to the bed, she records her pain experience in a numerical form. The pain severity of the right breast and the left breast are recorded separately, because there are some women who have different pain on the right and left side. Sometimes pain may actually be unilateral, and this pain chart allows the lady to record this differential pain on the two sides. Her menstrual experience is recorded separately in the bottom of the diary as monthly periods. This allows a clinician to see the pain experience on a day-to-day basis, not cluttered by the letter P on the day of menstrual flow, and one has the opportunity to record severity of the pain in a visual analog scale of 0 to 10 on day-to-day basis. An example of cyclical mastalgia with premenstrual exacerbation is depicted here. just prior to the menstruation, the lady experienced more and more severe pain starting around mid-cycle, that is the time of ovulation. Let us now understand the management of mastalgia. First of all, if the lady presents with any lump in the breast, we need to evaluate it by triple assessment, that is thorough physical examination to ascertain the nature of this lump and rule out cancer by appropriate biopsy. You will come across some ladies who hold their mammary gland as shown on this picture on the right side and say, "Doctor, I have a lump here." I can assure you, if lady holds her lump in sitting or standing position like this, she has created a lump in her mind. It is not there. Therefore, it is of paramount importance that we palpate the mammary gland only in supine position, not in sitting position as shown by this lady. Reassurance has been found in large number of studies to relieve breast pain in majority of these patients. So, we train the lady to fill her daily pain experience on a pain chart for 1 to 2 menstrual cycles. We offer her some lifestyle modifications such as wearing support undergarments. It should be tight, 1 to 2 size tighter in the daytime. Suppose a lady's breast cup size is 30, so she should wear 26 or 28 size breast cup brassiere in the daytime. However, she can remove it in the night. Regular exercise to keep the body weight under control and avoidance of excessive caffeine intake or coca intake if lady is consuming a large number of cups of tea or coffee, can also help some women. Recent studies have demonstrated the beneficial effect of flax seeds, which in Hindi called alsi seeds, and approximately 30 grams, that is 2 tablespoonful of consumption of flax seeds has been found to relieve mastalgia in a randomized trial. Therefore, we recommend to most patients presenting with breast pain. Please note that flaxseed is a rich source of omega-3 fatty acids. This slide explains to you how wearing a tight sports garment will relieve pain of breast. So, lady should wear a tight sports garment in the daytime, and in the night it can be loose. Breast tissue is suspended on the pectoral region by a series of ligaments called suspensory ligament of the breast. These were first described by Sir Astley Paston Cooper, hence they are also called Cooper's ligaments. These ligaments stretch from pectoral fascia on the back here. They traverse the substance of the breast to be attached to the dermis. In a lady endowed with large mammary gland, which is typically seen after breastfeeding 1 or 2 children, the breast tissue sags and there is some degree of ptosis here. Due to heavy weight, these Cooper's ligaments are pulled by gravity, stretching the pectoral fascia and the pain nerve endings attached to this part of the fascia and muscle. An appropriately fitting sports garment relieves the overstretched Cooper's ligaments and relieves the breast pain. Along with the sports garment and other support measures, we also recommend some systemic drug therapy if patient has severe pain. Local application of anti-inflammatory gel, piroxicam or diclofenac gel massage on the painful area of the breast has been found to be very helpful in randomized trials. So, it should be recommended to all women. Local anesthetic injection along with long-acting steroids such as triamcenalone acetate can be of very significant benefit to women presenting with trigger spot or trigger point pain. Sometimes you may find a painful tender nodule. An excision of such a painful tender nodule may benefit lady with localized breast pain of non-cyclical nature. So, lady comes back after filling her breast pain chart for 1 month. You have a look at this pain chart and find that even with these support measures, pain remains severe enough, that is, it is more than 3 on a scale of 0 to 10, and it is present for more than 1 week in a menstrual cycle, or pain is so severe that it is interfering with the activities of daily life of a lady. In all these 3 situations, you need to administer some systemic therapy in the form of an anti-estrogen therapy like Tamoxifen, 10 milligram once a day for 3 months. This is half the cancer dose in cancer breast with hormone receptor positive tumors. We recommend 20 milligram daily for a period of 5 years or even longer in some situations. Another anti-estrogen drug is called Ormeloxifene. It is recommended in the dosage of 30 milligram once a day or on alternate days. Danazol, an anti-gonadotropin drug, in the dosage shown here, has been found to be very helpful in a number of randomized trials and meta-analysis. Bromocriptine was also used with significant pain relief. However, due to significant side effects and the cost, its use has been abundant. So, a lady in whom pain persists and remains severe, that is more than 3 on a scale of 0 to 10, it lasts for more than 1 week in a menstrual cycle, or any pain interfering with the activities of daily life, we offer systemic drug therapy in the form of Tamoxifen or Ormeloxifene. Danazol and Bromocriptine are currently not used as first line drugs, as they have severe side effects and high cost. Tamoxifen or Ormeloxifene are usually prescribed for a period of 3 months. Application of anti-inflammatory gel such as diclofenac gel or piroxicam to the painful area 3 to 4 times a day is of significant benefit, as revealed by randomized trials compared to placebo gel. Our initial results of use of Centchroman in the benefit of breast pain and fibroadenoma were presented in this article and some subsequent articles to follow. Let me introduce this drug called Centchroman or Ormeloxifene. It was synthesized at the Central Drug Research Institute in Lucknow. It is a selective estrogen receptor modulator drug, and in this regard it is very similar to drug Tamoxifen. It has been marketed by Government of India since 1992 and has been included in the National Family Welfare Program as once a week pill for achieving contraception and family planning. Our study demonstrated that use of Ormeloxifene offered significant pain relief to women with both cyclical and non-cyclical mastalgia in a study where we compared the result of Centchroman with Danazol. So, after initial administration, within 4 weeks period, women in both the groups achieved significant pain relief, as demonstrated by visual analog pain score depicted on the vertical y axis here as a scale of 0 to 7. The maximum pain seen in this group of women was near 6. So, the pain score dropped dramatically within 4 weeks of administration of these drugs, and then the pain score reached a plateau, remained at in between pain score of 2 and 3 in most women, till we completed this course of medication for 12 weeks period. After 12 weeks, the medication was stopped. Interesting observation to note here is that women receiving Centchroman, which is depicted as the pain score with purple line here, they continued to experience significant pain relief till the end of observation period of 24 weeks. This is called prolonged carryover effect, which persists and offers significant pain relief even after stopping the medication for nearly 3 months. Women receiving Danazol did not enjoy that much of carryover effect compared to those getting Centchroman. So, another drug to use in women with mastalgia is Tamoxifen. It is used in half the cancer dosage, that is 10 milligram daily, empty stomach preferably, for a period of 2 to 3 months. If women have polycystic ovaries, then this is the preferred line of treatment, because Centchroman cannot be used in women who have polycystic ovarian syndrome. It achieves significant pain relief to the range of 98% for cyclical breast pain and around 56% for non-cyclical breast pain. It has minimal side effects when given in this half the cancer dose. Some women, however, will have mild symptoms in the form of hot flashes or vaginal discharge or irregular menstrual periods. However, these side effects abate as soon as you stop the medication. Danazol has been used in the past in the dosage shown here, 100 milligram to 300 milligram daily. Response is very good in the range of about 70%. However, it causes severe side effects in the form of weight gain, hair growth, masculine voice change, that is hirsutism like symptoms, and therefore, it is not liked by most girls. Moreover, it can cause significant menstrual irregularities. Evening primrose oil has been used in the past in many trials and has been found to be effective in about 2/3 patients. However, response is similar to that of the placebo in a meta-analysis, and therefore, it is no longer recommended. The systemic drug therapy is summarized on this table. We start with Tamoxifen, which is recommended for women having severe breast pain more than 3 on a scale of 0 to 10, given for a period of 2 to 3 months. Use 10 milligram daily for 3 months, that is half the cancer dose, and in this dosage it is very effective. It is very reasonably priced, 2 to 3 rupees a tablet, and has minimal and well tolerated side effects. All of these stop moment you stop the medication, and there is no risk of endometrial cancer or thromboembolic phenomena or cataract, which are often associated when Tamoxifen is used for breast cancer patients for 5 years or longer. Ormeloxifene or Centchroman is the preferred drug for severe cyclical mastalgia if ovaries are normal and there is no feature of polycystic ovarian syndrome. It is very well tolerated, is very effective in majority of these patients. It very reasonably priced, 2 to 3 rupees a tablet, and side effects again are minimal in the form of oligomenorrhea or even amenorrhea, which again gets controlled and menstrual cycle reverts to normal once the lady stops taking Centchroman. Danazol and evening primrose oil, Bromocriptine have all been shown here just to complete the list. However, they all have major side effects and they are all very expensive. Therefore, they are not currently recommended as the first line therapy. However, if patient is not getting relief by tamoxifen or ormeloxifene, one can switch to second line drug, that is Danazol. A systematic review on the current understanding and management of mastalgia has been presented in Indian Journal of Surgery, and you are encouraged to go through this article to understand the current guidelines. I now show you a lady presenting with trigger spot pain. She complained of severe breast pain. However, on palpation we found that pain was confined to just one spot where my finger is located on 3 o'clock of the left breast. On pressure in this area, she winced of severe pain. However, other parts of the breast were soft, supple, no nodularity, no tenderness at all. This is called trigger point pain or trigger spot pain, and this can be very effectively controlled by injection of long acting steroid like triamcenalone acetate mixed with a local anesthetic lignocaine. So, this injection of triamcenalone along with lignocaine is an office procedure and is very safe. You can perform it in your outpatient clinic with remarkable immediate relief of breast pain. We take about 2 ml of lignocaine 2% plain without adrenaline in one syringe and collect triamcenalone acetate half to 1 ml 10 milligram per ml concentration in another syringe. Keep these 2 syringes ready and start by injecting lignocaine gradually at the trigger spot, increasing the depth of injection slowly. As soon as you have hit the right spot and ascertain the tenderness, lady will tell that there is no pain on pressure. This indicates that you have hit the right spot, and then you change the syringe keeping the same needle in position and inject half to 1 ml of triamcenalone acetate, which commonly comes by trade name Canacort or Canalog. This can be repeated at 3 weekly interval for 3 to 4 injections, and most ladies presenting with trigger point or trigger spot pain get almost magical relief of their pain by 3 to 6 injections of triamcenalone. So, this is worth considering in ladies who have localized trigger point pain. A meta-analysis of commonly used medications for mastalgia has been carried out, and just to recap the results of this meta-analysis, which was the first meta-analysis of its kind for evaluating results of 4 drugs used for mastalgia, that is Tamoxifen, Danazol, Bromocriptine and evening primrose oil. This was published in the journal The Breast. When we compare the results of Bromocriptine versus placebo on a forest plot shown here, we can see that the pooled result depicted by this black diamond favors use of Bromocriptine as compared to placebo. Comparing Danazol with placebo, again women achieved significant pain relief compared to placebo. The Tamoxifen group, once again the pooled result presented as the black diamond here, achieved significant pain relief when compared to placebo. So, all these 3 drugs are significantly superior to placebo in relieving pain of mastalgia. When you look at the result obtained by evening primrose oil as compared to use of placebo, the black diamond, which is the pooled result of all the trials, was crossing the null value, indicating that some women had benefit, other women did not, actually had better benefit with placebo. In other words, there is about 30% pain relief with evening primrose oil, which is similar to placebo. Please note that in mastalgia trials, about 20 to 30% benefit can be accrued even by placebo. Many physicians have been using vitamin E, which is commonly prescribed by the trade name Evion. Let me inform you that prolonged use of vitamin E, especially in high doses, may be responsible for even brain hemorrhage or hemorrhagic stroke, as revealed by this meta-analysis published in British Medical Journal. In conclusion, we would like to tell you that mastalgia is the commonest breast symptom for which a lady presents in a breast clinic. It is mostly physiological, and reassurance and some supportive measures like lifestyle improvement, weight control, regular exercise, diet control, wearing a sports garment of appropriate size, using flax seeds help majority of women. Some women may require use of systemic drugs if pain is severe, lasts for more than 1 week in a menstrual cycle, or is more than 3 on a scale of 0 to 10. Use of Centchroman is very helpful, especially if ovaries are normal. If ovaries demonstrate polycystic ovaries, then use Tamoxifen for 2 to 3 months period, along with local application of diclofenac gel on the painful area can all go a long way in relieving majority of women suffering from mastalgia. Please note that the use of evening primrose oil and vitamin E or Evion are not recommended by the current evidence. Thank you.